Good evening and welcome to Doctors on Call. I'm Dr. Mary Owen, Associate Dean of Native American Health and Director of the Center for American Indian and Minority Health at the University of Minnesota Medical School. I'm also a family physician for the Fond du Lac Band. And I'm your host tonight for our program on upper GI problems. The success of this program is very dependent on you, the viewer, so please call in your questions tonight. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Jonathan Gapp, a gastroenterologist with Essentia Health, Dr. Chris Acoide, an internist with Aspira St. Luke's and faculty member at the medical school, and Dr. Dylan White, an emergency medicine physician at Aspira St. Luke's. Our medical students answering the phones tonight are Olivia Hoff from Rushford, Minnesota, Jocelyn Larson from Litchfield, Minnesota, and Allison Pulst from Alexandria, Minnesota. And now on to tonight's program, Upper GI Problems. Thanks for being here, everyone. I think until we get some questions, I'd like to ask you some basic questions that not everybody understands what we do or our training. So what does a gastroenterologist do, Dr. Gapp?
I kind of split my time between both clinic and doing procedures. So I do upper endoscopies to look in people's esophagus and their stomach and their small bowel. I do colonoscopies as well.
Okay.
And then I see patients in the clinic as well and talk about digestive problems.
Okay.
Health, yeah.
And lots going on in digestive problems or digestive issues in the last 10 years, the more we learn about microbiome. So you're probably getting a lot of questions on that from your patients these days.
Yeah, everyone wants to know about the microbiome. I feel like there's still a lot for us to learn as we learn how can we manipulate it and how do we keep it healthy.
Yeah.
So that, because it does make a big effect on how we feel. And I think we're still figuring out how much of our total health that it affects.
Fascinating, almost like immunology when we were in medical school.
Right.
You know, wide open still, probably still is. Dr. Coide, what's an internist? And what's an intern? I hear about internists, internal medicine, and then there's interns in residency. What is this all about?
All right, so an internal medicine physician takes care of sick adults. We don't take care of pregnant people and we don't take care of children. An intern is your first year resident. So they are fresh out of medical school. And let's see, what was else? Oh, I should say, in internal medicine, there are many different types of us. So some work in the clinic, some work in the hospital, and we call them hospitalists. Some work in the hospital and just at night, and we call them nocturnists. So there's lots of fun vocabulary there.
And you're a hospitalist.
I am a hospitalist.
Okay,
right.
Great. And Dr. Dylan, we've seen you a lot here. So
happy to be here.
Yeah. Yeah, no, it's great. I'm so glad you're here. It sounded negative.
Oh, I know.
So tell us why you're here for GI, gastroenterology.
So I like to say that emergency medicine does the first 10 minutes of every specialty. We, at that point, we see anything that comes in the door in the emergency department. Can be folks that are not very ill, can be folks that are critically ill, mortally ill even. And then with the help of some of our colleagues, such as consulting our gastrointestinal colleagues or others, depending on the problem, we can help stabilize folks, figure out problems, and fix them. And oftentimes, they then end up with our hospitalist colleagues if they're adults, pediatrics colleagues if they're children, or OB colleagues if they're pregnant.
So when you get someone who has a GI problem, the first thing you're going to do is call the hospitalist then if they're on call?
We do a lot of independent interpretation of talking to the patient themselves, lab studies, looking at their histories, and kind of figuring out, working with the patients to figure out what is going on. Depending on what's going on, they may be able to follow up with some lifestyle modifications, maybe some medication, or they may need to follow up in the clinic, or even may need to stay in the hospital for a period of time.
Thanks. Anything you two want to add to that? To what he does in his job? All right, we got some questions, so I'll save them. All right. Dr. Gapp, we'll start with you. Why might someone constantly be belching and having trouble keeping food down?
Belching, there's a lot of different reasons, but I would say one of the things that is kind of interesting is sometimes people will just be belching out the air that they've actually swallowed. So for some people, actually, it's almost an anxious kind of tic where they're swallowing air more than they expect that they are, and so then that air has to come back out, and so they'll belch. So that's one kind of reason. Sometimes we see people belching can be associated with things like an infection in the stomach, like H. pylori, which is a bacteria that can live in the the lining of the stomach. So sometimes that's a reason that we'll see belching as well. Or it could be part of that microbiome that we were talking about, where you have bacteria in your gut, and they take the nutrients that you're eating, they ferment it and create a gas, and then you can be belching that out as well. So lots of different reasons for belching.
This patient asked about trouble keeping food down. Can that belching have anything to do with keeping food down?
Yeah, I suppose if keeping food down, I suppose, I don't know if you know, that could be something like vomiting. And so sometimes if you're getting a lot of, like I talked about, fermenting, if you're getting a lot of gas buildup in your small intestine or your stomach, that distension can cause you to feel nauseous and then maybe feel like the need to vomit. Or otherwise, you could be having some regurgitation as well, you know, just kind of that almost an acid reflux, or where that fluid from the stomach is coming up and you're feeling that too.
Anything to add, you two?
Maybe we should say motility disorders can have a tendency to make one belch. So if you, for example, aren't moving your food contents through your intestine fast enough, certainly that would be a problem. If you have a problem with the lower esophageal sphincter, that little muscle that keeps your food from regurgitating, if there's a problem there. I mean, there's so many things.
So many things, yeah.
Right?
So many things that can cause
Right.
belching.
That's
yes.
what makes medicine fun. It's like a puzzle every time.
All right, Dr. Wyatt, how can I protect myself from getting norovirus?
Oh boy. First and foremost, wash your hands. For a full 2 singings of Happy Birthday Song or Twinkle Twinkle Little Star. We're talking a good amount of time, longer than you think you need to. Soap and water between the fingers, front and back, up to the elbows, the whole thing. If you do that frequently, every time you're out, you're touching doorknobs, anything like that, you will reduce your risk of transmission substantially. If you have diarrhea, please don't go out and do things that involve touching food, interacting with others, because you will be a typhoid Mary, so to speak, and spread it everywhere. It is very infectious. It takes very few particles of that virus to transmit the virus. So lots of hand washing and being mindful when you are ill will go a long way.
Thank you for that. Dr. Quiddy, can you tell us what some non-medicinal treatments for IBS might be? And if you want to punt this one to our gastroenterologist, that's okay too.
I think we all should answer because we all can probably contribute to this one.
Well, what is IBS first?
So IBS, that is the old term. Actually, we love to change names a lot in medicine. So IBS stands for irritable bowel syndrome. Now we call it functional bowel syndrome. Is that still right? Functional bowel syndrome?
Yeah, kind of interchangeable, yeah.
Right.
Yeah.
So, you know, you just want to be careful about limiting your alcohol intake, sometimes your caffeine. You certainly want to eat fresh foods, cook them thoroughly. If a food bothers you, certainly avoid it. Drink a lot of water. Let's see, I'm trying to think.
Yeah, I think things like fiber can be really helpful if it's the right kind of fiber.
Right.
So sometimes I think especially for like irritable bowel syndrome, people will say just take more fiber, but not all fibers are created equal. There are some that are kind of more soluble and non-fermentable, and so some of those, like psyllium husk, can actually be really helpful. It's soluble in water, it doesn't ferment a bunch, and so that can really help some of the symptoms too.
What's the common name for psyllium husks?
Well,
there's
brand names, but psyllium is kind of the common name. Yep.
Okay, that's good. Thanks for not saying the brand name. All right, Dr. Gapp. How do you treat, manage, or prevent phantom gallbladder pains? Surgery was 7 years ago.
How do you prevent gallbladder pains?
Yeah, they say phantom gallbladder. They had it taken out 7 years ago. Is there a way to help with that phantom pain that they're having? Well,
sometimes what I found is that the pain that's left over can be from some of the scarring from the surgery in and of itself. Sometimes massage of that area. If you're having continuing pain after a gallbladder removal, it can still be a good idea to get something like an ultrasound done. You can still get gallstones that were left behind and are still in one of the ducts there, and that can cause some pain too. So that's something that you'd want to bring up with your primary care doctor, and they could at least get an ultrasound, make sure that there's nothing still in that duct that was left over from either when that gallbladder came out, or sometimes those gallstones can reform even in ducts there and cause that pain too.
Thank you for that. All right, Dr. Wyatt. This is lower GI, but I think you can handle this as an ED doc.
Sure.
What are some effective treatments for my constipation, including non-pharmaceutical ways to manage constipation?
I think non-pharmaceutical ways is a great place to start, because a lot of constipation for us as Americans, we on average don't have the best diet, is lifestyle. So not enough of certain types of fibers, soluble fibers. Activity level is a big one. We don't get enough aerobic activity. Walking, jogging, doesn't have to be very intense. That does a really good job of stimulating the gut. Good hydration is another thing. If you do those three things and eat a lot of good fruits and vegetables, a lot of constipation will go by the wayside.
Thanks for that. Here's someone after all of our hearts. Dr. Coity, are people in general eating too much junk food?
Is that a trick question?
Maybe our med students ask this one.
Okay, no, that's a fair question.
Yes, it's a good one.
You're right.
It's a good one.
Depends on the person.
Yep.
Just like the variation that we see in everyday medicine. Some people are very healthy eaters. The reality is we don't eat very well. We're often on the run. We put ourselves last, especially young moms, young dads. Whatever it is. I've lived a busy lifestyle of a hockey mom, and I can't deny that I've gone through a drive-through a time or two. So we could all do better. I think just preparing food ahead of time and thinking through the process of, boy, we have to eat today. We have to eat 3 different meals. What am I going to do to prepare myself for the day so I can eat well? Including eat the rainbow, include a lot of vegetables, preferably. I always say try to get 5 in a day at least, then fruits, and then other types of fiber, and last would be meats, especially red meats. So if you can go vegetarian, I always say that's the best way to go, but that's not for everyone, and we're all different, so we'll take you wherever you come from. But yeah, I would definitely say we are not very, very good eaters.
And I think we need to give ourselves a break. People get down on themselves sometimes. Like you said, people are very busy. It's funny that this question came up. My daughter the other day told me that she grew up in an ingredients household. She was complaining about it because we didn't have enough junk food around. So that's one way to think about it, is not having those foods available so that you force yourself to cook these healthier meals. But we all are busy and get tired, and it's not always easy, and you have to give yourself a break.
And tomorrow is always a new day.
Well, tomorrow is Valentine's Day, so that's another story. Yeah, there's going to be a little bit of junk food going on. Yeah, and that's okay.
Right.
Dr. Gapp, can you explain autoimmune pancreatitis?
Yeah, sure. Autoimmune pancreatitis, is essentially the body's immune system that is attacking the tissue that makes up the pancreas. So there's a lot of different kinds of pancreatitis, right? You can get pancreatitis from gallstones. You can get pancreatitis from alcohol, and those are kind of the 2 most common ones. Some medications can cause pancreatitis. All of these are things that cause inflammation within the tissue of that pancreas, and as that tissue starts to kind of break down, some of the enzymes in that pancreas then kind of activate themselves, and you get this cascade of inflammation in the pancreas. And so for autoimmune, it's the body's immune system that is starting this cascade of inflammation, and then that's carrying down, creating the pancreatitis, the pain that you get. Yeah, that's what I would say.
How's it treated?
Normally, it's steroids or a way to suppress the immune system is what's needed for that. Yeah.
Thank you. All right, Dr. Ed. What is hiatal hernia, its cause, and how to manage this?
I'm
Dr.
sorry.
Wyatt. I'm sorry, I said Dr. Ed. Sorry about that.
I should know it. So hiatal hernias are essentially, the diaphragm is a barrier between our thoracic area, the chest, and the abdomen. And you can get, a hernia is just a slipping of some of the internal contents of the body through a layer of muscle, essentially. And in this case, the layer of muscle is the diaphragm. It pushes its way up, and the tissue that is going up there is the stomach, usually, through the esophagus, or the esophagus and the stomach sort of pull upward. Think like if someone was grabbing on top of it and kind of pulling it through. A lot of them are asymptomatic. Sometimes they have things like reflux that can happen, or they can be more serious and need either a gastroenterologist or even a surgeon to take care of it.
Anything to add, Dr. Yap?
It is often very common to see these when I do upper endoscopies. I would say that I think a lot of patients get concerned after they'll show me their reports from the past, or they'll come into my clinic. They'll say, you know, I had this scope done and it shows that I have a hernia. And a lot of people are thinking, you know, a hernia, can I see it? Is there a bulge coming out somewhere? And so exactly, no, you can't see it, but it definitely can cause symptoms of reflux. Once they get to a certain size, they can cause other symptoms because they're up near your lungs, and so some people start getting shortness of breath when they eat and things like that. So when they progress a certain amount, then that's when we ask a surgeon to step in and kind of get that anatomy back to normal again.
Okay. Dr. Coity, what is Barrett's esophagus, and does it always lead to cancer?
Well, hopefully not. But it is when the lining of the esophagus changes from the normal lining into like a precancerous-like lining. And that can be diagnosed with your friendly gastroenterologist and an upper endoscopy. I'm not sure.
This one seems friendly.
Anyways, always. So, and usually that's biopsy is performed to diagnose, to look at the tissue and make sure that it is not a natural, normal-looking tissue, but really a precancerous condition. So when a person, if you don't mind, I'll expound on that a little bit.
Please.
So when a person has it, we certainly want to make sure that we're decreasing their risk of that becoming cancer. And so we will minimize the acid exposure. So often those patients we will have on acid suppressing medications chronically. We don't like to use them all the time. I always say, like, I'd rather not be a pill pusher if I don't have to be. Certainly, one thing, we talk all about diet, but weight loss is so important too. And so losing weight would be helpful in this condition. And then lastly, I think surveying the situation to make sure that it is not progressing for somebody, especially who has a severe case of it. Did I miss anything though?
I just always make sure that if patients have Barrett's, that they're not smoking. Smoking
yes.
really contributes to the progression. So, and it's just it's a modifiable factor. If you can quit smoking, you really help your chances there.
Of everything.
Of everything, but especially for Barrett's.
So this person, a follow-up question from someone else, when they how often do they have to get rechecked for Barrett's esophagus?
So that depends actually on a lot of things. For Barrett's, we talk about Barrett's being a short segment, or we talk about it being a long segment. And as you can imagine, the more of the esophagus that is involved, the higher your chance that some of those cells start becoming, heading towards cancer. So if you're someone who has what I kind of tend to call kind of bland Barrett's, and those cells haven't changed at all, if you have a long segment that's more than 3 centimeters, then normally we have you coming back every 3 years, and we're taking biopsies. If it's a short segment, normally you can go about 5 years between those scopes. Now, if we do biopsies and it shows some of those cells have started making steps towards becoming a cancer, then the question becomes either much closer surveillance, so doing every 6 months to a year, or at that point maybe talking about trying to ablate or cauterize that Barrett's and getting rid of it so that that risk of cancer is decreased.
Okay. These next 3 questions all have to do with acid reflux. And Dr. Coity, you mentioned something first of all. So what can you do for acid reflux? But you mentioned one of the treatments for Barrett's, the same is related to the treatments that you use for acid reflux. And there are a couple of medications that we commonly turn to. Can you explain what those are? The
Sure.
H2 blockers and proton pump inhibitors. Can you explain to the audience what those are?
Yep, I'll try to make it simple. So one just takes acid and neutralizes it, and another prevents acid from being made. And so I kind of simply put, but the proton pump inhibitors are usually stronger medications that will often use for very severe cases. Maybe more mild cases can use the H2 blockers. And the reason there's important, we should think about the differences because there's some sequelae or some things that happen when you are on these medications for the long term. So for example, if you're on proton pump inhibitors for a long time, you're more at risk for things like osteoporosis, you're at risk for obtaining the infection, a C. diff infection if you're on an antibiotic, and other things. So those medications are used, but I always think like it's lazy if you are a physician and you're with the patient on their annual exam and you're not looking through their med list and making sure that they need that medication still, or maybe if they don't. So that's one that I think about a lot because maybe they need it if they have Barrett's, but maybe they don't. Especially if they've lost a lot of weight, maybe they quit smoking, whatever it is, maybe their reflux is gone, but we just continue it. That's one that I go after. If we can stop it, I try to.
All right, thank you for that. Let me see, what warrants, Dr. White, what warrants an endoscopy?
So from my side of things, there can sometimes be a need for emergent endoscopy when we have folks who have, for instance, lost a lot of blood. Their blood count has dropped and we don't quite know why. Or maybe they have darker stools. The blood that happens bleeding in the stomach is digested, actually. The blood is, and it comes out very dark. So if you have dark stools, please talk to your doctor about it. But that can be a need for an emergent endoscopy for bleeding or for big blood vessels that have formed called varices. We can sometimes see that. On a longer term basis, it may be recommended by either your primary care doctor or a gastroenterologist for conditions of either monitoring Barrett's, diagnosis of Barrett's esophagus, or to look for maybe ulcers, or even, I believe, obtaining samples for things like Helicobacter pylori infections, that bacterial infection as well. So many, many different reasons, but essentially it's not imaged well, the stomach, right? Externally, a CT scan can see the lungs pretty well, but it doesn't look at the heart very well. So you sort of have to go in and actually look with the camera, which is sort of the role that the endoscopy plays.
Anything to add, Dr. Gap?
Yeah, I would agree. I mean, there's a lot of reasons to do endoscopy. You know, it's also part of the diagnosis for things like celiac disease. It basically allows us to go in and take biopsies, which, you know, you can always look at a picture with a CT scan, but to be able to go down and take pieces of tissue that can then be looked at under a microscope can be helpful. So like I said, things like celiac disease, or another thing is people who have trouble swallowing. That's one that I do endoscopies for oftentimes. One, we want to make sure there's not something big, bad, or ugly like, you know, a cancer in the esophagus, but oftentimes it can also just be, if people have trouble swallowing, it can be from really bad reflux, and then we know what's going on there and we can begin to address it with lifestyle or medications if needed. So that's another reason why I do a lot of endoscopies.
All right, Dr. Gap, one more. Can nighttime reflux cause a sticky film in your mouth in the morning?
It can. I hear mostly people say they wake up coughing, or they have kind of a sour taste in their mouth. So I suppose a sticky film, I mean, do you have gastric contents that are coming all the way up? I would not say that that is diagnostic and means that you for sure have reflux because of that sticky mouth, but I could see that being one of the symptoms of reflux.
Dr. Cordy, what are non-medical things that you could do for acid reflux?
Oh, so you can make your bed a slope. You can elevate the head of your bed. You can quit smoking, minimize your alcohol intake. Really importantly, you can lose weight. Let me think. You can avoid food that might be causative for the symptoms of reflux. So those would be things that are not medication that you can do to treat without even going to your doctor.
Dr. White, I want to ask this one. We might run out of time, so I might move you along, but this is an important one. How can you distinguish between reflux pain and chest pain, what we were just talking about?
Yes, and that's a challenging one because the nerves are kind of right in the same area and you can get very similar sensations. Heck, we call it heartburn when it's not the heart, right? It's the stomach. A big thing is exertion. Usually if pain comes with movement, exerting yourself, that's usually not the stomach. And if it's new, I would always be cautious, especially if there's not something you can put your finger on. You didn't just eat spicy food or drink or smoke or do something like that. You have that pain all of a sudden, that's a little more alarming, potentially.
Anything else to add, Dr. Gap?
I would say also you can sometimes if you've ruled out like heart problems, then if you start on an acid suppressing medication, then that can kind of help to differentiate the two as well, just for a short course. But yeah, always the heart first is what we say.
Yes.
You got to check the heart
Yes.
first, because heart problems can hurt you. Reflux, we've got some time.
Yes, you have to kind of rule out
Yeah.
the heart problems often before you can move on to saying, okay,
Exactly.
now we've ruled out that you're not having a heart attack. Hi,
Yeah.
this is our friendly neighborhood gastroenterologist. We'd like you to meet him.
I think we got about 30 seconds. Treatment for acid reflux in infants.
Oh, we don't have a pediatrician.
I don't. Yeah, I
I think
treated
they're
it.
both
It's basically the
They're
same.
similar.
It's
It's
the,
in the
back of my
yeah,
brain.
One
it's
thing
the
I
same.
would notice though,
Yeah.
infants can have pyloric stenosis,
Yeah.
and that's one thing that you don't want to miss that diagnosis because it's a surgical problem. So if there's, infants can't always tell you. It's kind of like, yeah. So you would probably want to seek medical care.
Frequent smaller feeds, I think, is a big one they mention. So if you're having trouble, frequent smaller feeds.
Thanks you all. We ran you right to the end. I want to thank our panelists, Dr. Jonathan Gap, Dr. Krista Coity, and Dr. Dylan Wyatt, and our medical student volunteers Olivia Hoff, Jocelyn Larson, and Allison Polst. Please join Dr. Ray Christensen next week for a program on lower GI problems, when his panelists will be Dr. Ryan Harden, Dr. Paul Sanford, and Dr. Sandy Stover. Thank you for watching, and good night.